Thanks everybody for joining us at Georgia MemoryNet Insights today. We're glad to have Dr. Gabriela Cohen with us today to present. She is an associate professor in the Division of Geriatrics and Gerontology. She's a memory specialist. She's the director of the Grady Memory Clinic. She's a provider in the Grady-based Georgia MemoryNet, a memory assessment clinic, and she's also co-director of Georgia MemoryNet Insights. Dr. Cohen, glad to have you today for a really interesting topic. I'll turn it over to you. Thanks.
Thank you so much. Good morning to everyone. I guess it's 12 and we can get started. Thank you so much for the invitation and the presentation. Should we wait or do you want us to start?
We are all set, all ready to go. Thanks so much.
Excellent. Okay, perfect. So this slide is very important. I don't know if you just want to add anything. This is to be accredited as Georgia MemoryNet sites, okay?
Yeah, let me just offer just a couple of comments. New for Georgia MemoryNet Insights this year in 2026 is that we're moving to our friends at Morehouse for our accreditation. And so people should register. You can scan this QR code or follow additional information that we'll put at the end. Also new in 2026 in this webinar is that we've enabled the chat feature. So you can use the chat feature to go ahead and let us know as directors if there's something going wrong with the presentation. And we also have the Q&A box where I'll monitor questions and tee them up for Dr. Cohen. Hey, thanks so much.
Okay, so today we're going to talk about early onset dementia, clinical manifestations, and the reason why I decided to talk about this is because at Georgia MemoryNet, I'm the provider at the Atlanta, one of the providers at the Atlanta MAC, and I've been seeing more and more cases of early onset, and I think that they have distinctive features, and I think it was worth to give this presentation to give an update on this subject. So I have nothing to declare. So the objectives, we're going to review the distinctive clinical presentations of early onset dementia and always trying to compare to late onset dementia. We're going to try to talk about where there is a neurodegeneration composite or not. We're going to try to study the profile on neurocognitive assessment and again, making always a comparison with late onset dementia and try to review a little bit of the features of neuroimaging going through two cases that I recently see at the Georgia MemoryNet MAC here in Atlanta. So a few epidemiological data. This is rising. So not only here in this MAC, we're seeing more and more cases. Overall, early onset dementia, it seems to be increasing. It's expected that the prevalence, if you see down here, it will increase 160% by 2050. It really depends the incidence of the age of the population. So between the age and 45 and 64, we could find up to 98 to 163 cases, up to 1,000 people. And it's lower in the younger population. And so what's the definition? We define early onset dementia is when the first cognitive symptoms started before age of 65. So for us, 65 is the kind of the limit. So it doesn't mean that the patient gets diagnosed with dementia after 65. It means that the symptoms started before age 65. So the differential is much broader. So for memory experts, we need to really pay more attention because we have different diagnoses. Still, the main causes in this population of early onset dementia are the same diagnosis that we see in late onset dementia. We see first Alzheimer's disease, frontotemporal degeneration, and vascular cases. But again, as I say, the differential is much broader. And we need to make a rapid and correct diagnosis. These are people who are still working, who have a lot of psychosocial needs, and who may start having cognitive symptoms that affects their daily task. And it's super important to make the right diagnosis quicker. Genetic disorders are more common compared to late onset dementia and late onset, I just abbreviated with LO, but still the majority of cases with early onset, we don't find a genetic identifiable cause. We have higher risk of vascular disease and we have higher risk of patients who suffer traumatic brain injury and repeated concussions. So I thought this slide was kind of interesting because when we're dealing with early onset dementia, again, patients who started with cognitive symptoms before age of 65, it really depends on the age of the population and the frequency of different diagnoses. So if our population is between 50 and 64 years, Alzheimer's disease is by far the most common diagnosis. Frontotemporal dementia is really important in this age group with 13% of the cases. We still see patients with Lewy body dementia in this early population, although Lewy body dementia is much more common later on in life. And then we have vascular dementia, alcohol-related dementia, 15%, and then we have this kind of 12% in red that is other diagnosis, okay? And we're going to see that as we deal with patients who are younger, this part of other diagnosis started to grow, and the Alzheimer's part is going to decrease, and frontotemporal is actually increasing. And this is on the second pie is the population between age 45 and 49. So more of these other diagnoses that could be non-neurodegenerative diseases, anxiety, depression, psychiatric disease, cancer, brain meds, hypothyroidism. This is really high on the other diagnosis. And the last slide I put, the population between 40 and 44, we could see these other diagnoses, degenerative and not degenerative diseases really increasing in frequency, and Alzheimer's disease is much rare, okay? And frontotemporal is still high. So it really helps to kind of nailing the diagnosis to know the age of the population. So I thought this was interesting because we usually think about dementia and we think about the amnestic presentations, but we have different presentations, and some of these different presentations, non-amnestic, that they don't have memory problems, are really much more common in younger population. Interesting here, we have the first syndrome that we're going to define, posterior cortical atrophy. This is definitely a non-amnestic presentation of dementia, and it's definitely much more common in young onset. Then, of course, we have here the familiar Alzheimer's disease presentation, which is really genetic autosomical transmitted and is definitely affecting patients at young onset. Then we have the big group of aphasia, primary progressive aphasia. These are language presentations where the language is the main cognitive domain affected, and this could be to different diagnoses and to different pathophysiology, but usually we see primary progressive aphasia in young onset dementia. And then we have frontotemporal dementia. Some of the frontotemporal dementia have a genetic component, and definitely we see patients at a young onset dementia presentation with frontotemporal degeneration. So what are the features talking about Alzheimer's disease in particular? In which way we can differentiate patients who present with early onset Alzheimer's versus late onset Alzheimer's, and this is usually how we abbreviate. So in general, early onset Alzheimer's affects 5% of all cases of Alzheimer's, so it's relatively rare. And most often it's really sporadically, but we have higher frequency of genetic mutations in this early onset Alzheimer's disease population. Up to 1 to 10% of the cases could have an autosomical genetic transmittal component. The main risk factor to have an early onset Alzheimer's is the family history of early onset dementia. And it's interesting that there are different clinical presentations, and we usually split in amnestic. That means that the main cognitive domain affected is memory versus non-amnestic. And it's interesting that the non-amnestic presentations are harder to diagnose and actually are much more common in this young population. Early onset Alzheimer's disease is related to delayed diagnosis, more aggressive course, unfortunately. And as I said at the beginning, it has all these age-associated psychosocial needs because these patients are usually working and they are not retired. And interesting, they have higher prevalence of non-cognitive symptoms. When we talk about non-cognitive symptoms in Alzheimer's disease, we talk about an array of different symptoms, but usually the most common at the beginning when we made the diagnosis are anxiety and depressive symptoms. Later on the disease, we usually have more psychotic features, hallucinations, and more paranoid ideas, but at the beginning, anxiety and depression are very common, especially in this young population. So that's kind of a graphic. When we have Alzheimer's disease, we have typical amnestic presentation where the main cognitive domain affected is episodic memory problems, is the memory of the episodes, the memory of things that just happened, versus these non-amnestic presentations. And usually there are three very good groups described. The first one is posterior cortical syndrome. The second one is progressive primary aphasia, and usually logopenic progressive primary aphasia is due to Alzheimer's disease pathophysiology. And the third one, and that's why I put this kind of slides where the part of the brain that is affected is this frontal variant, where patients present with more behavioral symptoms, very similar presentation to patients with behavioral frontotemporal dementia. So having non-amnestic early onset Alzheimer's disease, they really compose 22 to 64% of all the cases of early onset Alzheimer's. As I said before, you could have a language and more apraxia and visuospatial, kind of limited to the parietal lobe syndromes, and we call this posterior cortical syndrome, or you could have a more frontal presentation with behavioral symptoms. It definitely has more aggressive course compared to amnestic, and less frequency of the ApoE44 variant. So when we identify a patient with early onset dementia and early onset Alzheimer's, we have two main groups that we could refer the patients to. One is the DIAN, and DIAN stands for Dominantly Inherited Alzheimer's Network. If we see that there is a pattern, a family history where each generation is affected, we could definitely think about enrolling the patient on DIAN. And the other big research group is the LEADS. LEADS stands for Longitudinal Early Onset Alzheimer's Disease Study, and these are patients who present with early onset dementia without a genetic component. And we have these different resources to kind of help families and also to do research. So we're going to go through two cases, and I want to see what you guys think about this. So these are two cases that we saw recently here at the MAC in Atlanta. The first one is a 50, very young year-old female who presented with episodic memory problems that really started 2 years before presentation when she was 48. At the time I saw her at the beginning, she was totally independent in all her instrumental activities of daily living, and she was previously seen by a neurologist, and she was diagnosed with attention deficit disorder. Her educational level is college degree. During the interview, I was surprised because she was very repetitive, and this is kind of the qualitative information that is really rich during the interview. And her mother had dementia at age 60. There is not any other positive family history. So I saw her at the beginning, a patient 50 years old. I thought maybe diagnosed with some psychiatric disease, ADH, but I was surprised when I started with the screening test, and when I did the MOCA, her MOCA was only 12 out of 30 for someone with a master's degree and more than 16 years of formal education. So this is the result of the full memory test that we did here at the unit. And the way this is like a pie where the dark bars shows the cognitive domains affected, and they're affected below 2 standard deviation from the media. So this is the result of which cognitive domains are definitely abnormal. Less than 5% of the population at this age will have these results. So she was very affected in memory. Memory was definitely the cognitive domain most affected, but her attention was also affected, her executive function was affected, and her visuospatial. The language was the cognitive domain less impaired. So this is the first question. You're in your clinic, primary care, you have a 50-year-old lady with these symptoms, you do a MOCA is 12. What is your most likely diagnosis? Do you think this could be normal changes due to aging? Do you think it's likely a neurodegenerative disease, or do you think it's likely a non-neurodegenerative disease? And we see some answers here. Thank you so much for participating. This is much more fun to do participative. We'll wait a little longer. Okay, so we have 19 answers, and I guess we could kind of see the results. So almost 95% of the audience think that this is likely a neurodegenerative disease. Very good. Let me close this. Okay, so of course that was my diagnosis. I was very concerned about this lady. I was very surprised that she was repetitive, these results of the cognitive test. So this is the result of her brain MRI. And I usually like to start seeing at the MRI on the sagittal to have a general idea of what's going on. So we identify the structures, we identify the frontal, the orbitofrontal part, we identify the lateral ventricle, we identify the corpus callosum, the cingulate circus just above the corpus callosum, and then the thalamus and the midline structures, the cerebellum. And we definitely see that the seizures, they're really roomy. And we definitely surprised that at the midline, in the parietal lobe, we definitely see some atrophy that, of course, we had to put this in perspective that this patient is only 50. So for this age, I would say that there is some degree of parietal atrophy. This is another cut, the one in the middle, where we identify the midline structures a little more. And then here we go parasagittal and we identify the hippocampus here. The hippocampus looks really good on the sagittal. There is no significant hippocampus atrophy. The temporal pole looks really good too. And down here we have the choroidal cut where we see the hippocampus and the entorhinal cortex, and there's definitely not significant atrophy on the hippocampus. So my conclusion on this MRI is that for this age, I was kind of surprised for this parietal cortical atrophy, but without any hippocampal and entorhinal cortex significant atrophy. So in patients with young onset dementia, of course, we usually do much more biomarkers. She's young, we really want to nail in the diagnosis. So in this case, we did biomarkers doing a spinal tap, and her results are very consistent with Alzheimer's disease pathophysiology. She has a very low measurement of beta amyloid in the CSF. That means that the beta amyloid got stick to the cortex. So the lower the measurement of the CSF, the more amyloid stick to the cortex. We have a high total T total value that usually has to go with neurodegeneration, with a very high phospho-tau that has to do with the pathophysiology of Alzheimer's disease. And then we do these ratios, and the lower this number, this ratio ATI, the more consistent with Alzheimer's disease. So definitely after seeing the CSF, the neurocognitive assessment, her clinical symptoms, we could see that her diagnosis is early onset, amnestic presentation, and clinically she was able to do all her EADLs. So her final diagnosis is multi-domain mild cognitive impairment due to Alzheimer's disease, or another way of calling this is prodromal Alzheimer's disease. I also did phenotyping for ApoE, thinking that she could be a candidate for anti-amyloid drugs, and she was ApoE44. So we have a second case. We have a 61-year-old male who presents to social memory net with a main complaint of episodic memory problems with impairments in almost all his instrumental activities. He is independent in his basics except for dressing. He had a lot of difficulty putting his clothes on. It takes him very long time, and he definitely has difficulties with that. And we call this dressing apraxia. He had severe visuospatial problems. He was previously referred to the eye clinic thinking that he had some eye clinic problem, but he was clear about that. So his diagnosis is visual agnosia. He can see the pictures. His eyes are okay, but he has difficulty interpreting what he sees. He's no longer able to drive. He had simultagnosia. That means difficult to find objects like his cell phone when there are multiple objects on the table, even though they are reachable. And at this time, with this presentation, again, what do you think is the most likely diagnosis? So we have a 60-year-old patient who presents with visual agnosia, with dressing apraxia, with visuospatial problems. So we have three options: frontotemporal dementia, mixed dementia, or Alzheimer's disease.
And the poll is launched, and we're waiting for responses. About half of the people have given a response, now up to 65%.
This one is harder, huh? I could have
Okay.
made this easier, but I wanted to make this difficult. So this question is actually tricky. So, and I can see the difficulty interpreting this. So 26% thinks it could be frontotemporal, definitely the age of presentation, and I haven't shown you any results yet. 39% it could be mixed dementia, and 35 think it could be Alzheimer's disease. Good. Thank you so much for putting your input. So going on with the case, he has a negative family history of Alzheimer's disease. I did a MOCA, and the MOCA was 6 out of 30. So this is really impaired. The way we interpret the MOCA is really useful to go horizontally through different domains. So if you remember the MOCA, the first domain is visual spatial. So we have the mini trend making B, where it's a test for visual spatial, but also executive, because we ask patients to alternate a letter with a number. So he has severe problems with the mini trail banking B. He has severe problems copying the cube, and he definitely has severe problems with the clock. So I could say that the MOCA was 6 and almost all the cognitive domains were impaired, but definitely visual spatial was very impaired. So this is his MRI. Again, I put only a few pictures. We start with the parasagittal. We identified the lateral ventricle for his age. He definitely has some ventriculomegaly with some diffuse atrophy, but you could see that there is a pattern of atrophy, anterior, parietal, and posterior, but definitely in the parietal lobe, in the posterior part, you see much more atrophy compared to the anterior. This is parasagittal, where we get to see the hippocampus. So the hippocampus is kind of occupying all the space. You see a very small dilatation of the choroid fissure up here, but I would say that there is no significant, definitely not very significant hippocampal atrophy. There is much more parietal and posterior atrophy. This is a tissue flare of the axial cut on the top parts, where we could see this pattern anterior and kind of parietal, and definitely there's more atrophy in the parietal. Okay, so in this case, in his MOCA was 6. I thought that I definitely needed more diagnostic certainty because of the age of presentation, but I thought that blood biomarkers would be good enough, especially if they were positive and they were kind of congruent with my clinical diagnosis. So I only did a measurement of p-tau 217 in blood, and that was very positive. So and this is the coronal cut, where we can see the hippocampus and the entorhinal cortex. There is very, very mild hippocampus atrophy. That's kind of congruent with what we see on the sagittal pictures. So his diagnosis in this case is early onset dementia, because he presented before age 65, and his clinical syndrome is posterior cortical syndrome. And the most common cause of patients presenting with posterior cortical syndrome is due to Alzheimer's disease pathophysiology. So this is his final diagnosis in this case. So I think, Ted, going back to you, we can leave some time for questions or comments on these presentations. I just put 2 diagnoses, one patient presenting with amnestic syndromes and another patient presenting with non-amnestic presentations. I will be following these patients to see where this is going, but these are really tough diagnoses, because again, we are diagnosing patients who are working, who are young, who are fathers, who are not even grandparents, and who have these really severe diseases. Thank
Dr.
you. Going
Cohen.
back to you, Ted.
Yeah, Dr. Cohen, thanks for a great presentation, really informative, and thanks so much for bringing some real cases from the Atlanta, Grady-based Georgia Memory Assessment Clinic. So I'll continue to look for questions that appear in Q&A, and so I see one. Also, just be aware that if you use the reactions button and raise your hand, we can also elevate that. Dr. Soma, Jula, do you want to come on and just talk about this question here? Dr. Cohen, you should be able to see it there.
I'm sorry, I'm not reading the question.
Got it. Are you still able to order PTAU 217? We received information, a recall on the FDA-approved biomarkers from LabCorp and Quest Diagnostics. To you, Dr. Cohen.
That's a good question. So I didn't read the recall yet, but what we know is that there are different assays and some of the assays are approved. So you really should try to use the assays that are FDA approved. At Emory, I think we use the assay that is approved. At Grady, it's a work in progress. So really, we should use. I think this is coming, and that definitely some of these assays are approved, and you should be sure to use the assays that are FDA approved. Good question.
Got it. Thanks so much for that. Folks can put questions in the question and answer section or raise their hands. Ashley Varner, you put a couple of really informative things into the Q&A, which I put onto the chat. Do you want to come off and mute and just offer some guidance on that?
Sure. From a psychosocial point of view, obviously, folks with early onset Alzheimer's and other dementias are facing, as Dr. Cohen mentioned, so many other challenges. And one of them is that support groups are filled with folks that they don't relate to at all. And so there are a couple of resources. The Alzheimer's Association has an ALZ Connect, which is a bulletin board type setup, and an entire arm is dedicated to folks with early onset Alzheimer's disease and their care partners. Here at Emory, we've also partnered with the Alzheimer's Association to offer a support group. I'm trying to find the link actually on the alz.org page, but it is offered the third Tuesday, which was yesterday, of every month from 6:30 to 7:30, and it's an incredible group of care partners who are caring for loved ones with early onset and are tremendously supportive to each other, both in terms of providing information and emotional support.
Super helpful. Thanks, Ashley. I really appreciate that. Dr. Cohen, Dr. Vora Culler has a question here that I'll read out loud.
Yeah, I can read that.
Okay, great.
So the question is, we often see patients in their 50s who are concerned about their memory. Is a mini-cog sufficient as a screening test for these patients? And I lost the question. So that's a good question. So remember that the mini-cog, it's a good screening test, and it has a high negative predictive value for dementia, but not for mild cognitive impairment. So you could definitely have a patient with mild cognitive impairment with a normal mini-cog. You're just doing a screening. So it's a good thing to do it, but I think if you ask me my personal opinion, for example, the first patient, she could have a normal mini-cog, but she still have a MoCA of 12. So it's a very easy test, a mini-cog. In just 3 minutes, you address for the late recall of 3 words, and then you do 1 point for all the numbers in the clock and 1 point for the correct time. So again, has a high negative predictive value for dementia, but not for MCI. So yes, you could have someone with definitely concerns for a neurodegenerative disease on a normal mini-cog. So I think that it's a good start, but you definitely need to do something else, not just stay there. And that's why the dementia specific interview and asking about symptoms and how those symptoms had any impact on the functional assessment are really significant. So, and that's why I put the first case. I really was expecting this patient to not have a neurodegenerative disease, and I was really surprised about how repetitive she was during the visit. And these patients many times get diagnosed before we see them with, anxiety, depression, different psych diseases, but really what they have is an underlying undiagnosed neurodegenerative disease. Good question.
Dr. Cohen, go ahead and advance the slides. We've got just a couple of things. We wanted to collect some information about who's joined us today.
Yes.
And perfect. We'll leave it there. It's me next week. I'm sorry, next month, looking at pretest probability and what that means with regards to commercially available tests for pathology. Thanks, Dr. Cohen. And
yeah, let me put the last slide.
Yep, thanks so much.
So this one is
great. Here's your final poll. Go ahead and just fill that out. Let us know who you are. Appreciate your joining us today. 60% of the folks have answered so far. And we'll go ahead and end the poll right now with 75% answering. And
Okay.
thanks so much. That's who's joined us. Appreciate you coming today. Go ahead to the next slide, Dr. Cohen. Great.
So
That's
February
me for,
18
yep,
by Ted. Perfect.
great. And
Good.
next slide. Great. And here's information about how to let us know your thoughts and information. And I think there might be one more slide.
Yeah.
Great.
How to create the Morehouse CME account. That's important to get
Great.
credit.
And is there one more slide? Great. All right. Well, thanks so much for joining us today on Georgia Memory Net Insights. Shout out to Dr. Cohen for a great presentation. Really appreciate Kim Reese doing a lot of practice runs on the Zoom webinar to get a couple of features back that we know will help you be engaged and let us have a community here without being pirated by evildoers. All right. Thanks so much. Looking forward to joining you next time.
Thank you so much for joining us. Thank you. See you next month.